Dr. Megan Kasper, how are you?
I'm doing well. It's good to be here.
Good to have you here. You and I connected months ago on women's reproductive rights. I really enjoyed that conversation. I learned a dump truck. And you are back now to talk about different medications that are being, or people are attempting to outlaw them in the state of Idaho. Medications that, yes, in other states are used in elective pregnancy terminations, but they are also used in normal disease management with pregnancies. Like if somebody has had a miscarriage, conclusively they've had a miscarriage, there are medicines that are used to help that woman recover and deal with the situation, not elective pregnancy terminations. And because these medications are being used in other states for elective pregnancy terminations, there are legislators here that are looking to outlaw those medications. Now, again, it is already illegal in this state to have an elective pregnancy termination outside of rape, incest, and life of the mother. It would be illegal to use these drugs to one of those ends. It's already illegal, but they want to make the drugs illegal even though they have utility outside of that very specific usage.
Yeah. Yeah, it's an interesting problem because these are medications that we use on a regular basis. The two medications in question are misoprostol, which is a prostaglandin medicine, and mifepristone, which kind of the simplest way to think of that is an anti-progesterone. So progesterone is one of the female reproductive hormones that helps maintain a pregnancy. So keeps the uterus from contracting and expelling the baby as the baby develops. So misoprostol, just to go into a little bit of how these medicines are used. So misoprostol.
Pull this a little bit, just a little bit closer.
Great.
There you go. Perfect.
Misoprostol is used for a ton of things. So we use that in labor induction. So it's been used a ton in recent years as something besides oxytocin or pitocin, which
Gotcha.
Most people have heard about, and the IV medicine, and it makes the contractions really strong. And misoprostol as a prostaglandin works through a different mechanism, and it has been very useful for labor induction. And we use it in very, very small doses when we use it then. In big doses, it's been a huge player in postpartum hemorrhage treatment. So women who've had a baby and they're bleeding too much, misoprostol is one of our primary medications to treat postpartum hemorrhage. And it's actually been a really big deal in third world countries because it's a cheap medication. So women's health is always interesting because there's actually not a lot of money in women's health. And so it's difficult to get new medications, get those medications out to where they need to be. Misoprostol as a prostaglandin medicine has been used to prevent gastric ulcers for decades, like ever and ever and ever. So it's generic, it's cheap. And in third world countries, it's been a big player in treating hemorrhage because it's just a pill. It's shelf stable. It doesn't need to be refrigerated. It's cheap. It's easy to get into the hands of community health workers. So it's made a big difference in mortality from that in third world countries specifically. Here in the U.S., we do have other options.
Gotcha.
We still use it a lot.
And if I may, and again, I'm not really, okay, so you have a baby, okay, and then your uterus doesn't contract sufficiently, and so you continue hemorrhaging, and obviously you have to get the uterus to contract and close back up, close blood vessels and whatnot, and so that the bleeding stops, like you have the baby out. And in the absence of that contraction and closure, then you can continue bleeding out and eventually die if not treated. Got it. So misoprostone, it sounds like, did I say
misoprostol.
Misoprostol.
Yeah.
Okay, I'm just going to call it meso. So that essentially helps to encourage that contraction so that bleeding stops.
Yeah.
Got it.
So that's one use. In early pregnancy complications, we use it for miscarriages. So it's now with our current technology, most women who find out they're pregnant in the U.S. have some sort of dating ultrasound early in pregnancy. And so we catch miscarriages a lot of times before a woman has any cramping or bleeding from that miscarriage. And there's very specific, very well-researched criteria for, when we call that. So there's specific measure, if a pregnancy gets to the sac gets to a certain size, if the embryo, the developing baby gets to a certain size and there's no heartbeat, if you saw a heartbeat and then look 2 weeks later and there's no heartbeat anymore. So it's not like we're just making this up. Like there's very specific criteria for this. But one of the options when we identify what's called it's called a missed abortion medically, or missed miscarriage. So the pregnancy has stopped developing. The baby is no longer alive if there is a baby there. Sometimes the miscarriage happened, the pregnancy stops developing before a baby even forms. When that happens, you've got 3 options. You can do nothing and just wait for nature to take its course. You can use medication, of which misoprostol, and then the other medication, mifepristone, that I'll talk about in a minute, is one of the medications we use for that. Or you can do a surgical procedure. And so in the treatment of a miscarriage that hasn't started to physically happen yet, or the woman's body has not started to expel the failed pregnancy yet, you've got all 3 of these options. And there's statistics on how far along you are and how likely expectant management is to work, and medication, and of course, surgical DNC always works, but a lot of women are wanting to avoid that. That's expensive. You have to go to the OR. So you've got the OR cost, you've got the anesthesia cost, and then the procedure cost. It's usually a day off of work or away from childcare for the woman, and whoever's with her. So it's it's a little bit more involved logistically. And so having other options now, it used to be back in the day when my mom was having babies, if you had a miscarriage, if they found out you'd had a miscarriage, they just signed you up for a DNC. Like that's what they thought needed to happen. And over the last 40 years, we have tons of research in, what it looks like if you wait for a woman's body to do it on her own. And that actually works a lot of the time. One of the downsides to that, though, is it could take 4 to 8 weeks. And that's hard for women to know, that they have their pregnancy is not continuing. And it's just, this thing hanging over their head for a long time. So it's a perfectly valid and safe option to wait. And depending on how far along you are, 80% of the time that just goes on its own and doesn't need any more intervention. But then medication is an option. And a DNC is an option. And one of the interesting things...
may I
Yeah.
may I ask a question? I'm sorry to interrupt. I know you're on a roll. You give me a lot of info.
I get on a roll really easily. So
with the letting nature take its course 4 to 8 weeks, did you say 48 or 4 to 6?
Up to 8 weeks.
Up to 8 weeks, okay. Mm-hmm. Theoretically, that expulsion could come at any time.
Yeah.
I asked because I had a family member who actually was pregnant and then had a miscarriage, and it did not come at a good time. She was actually at a social event. She went upstairs and then, realized like, oh my God, I need a change of clothes. Mm-hmm. I need help right now. Mm-hmm. It was a really, really traumatic experience for her, and she also couldn't get a hold of her husband because he was working under, he had security clearance and was in a secure area at the time. And it was a very, very traumatic thing. And I was, when my wife got pregnant and we started having our kids, I made sure, because knowing this, it was like, wow, that's crazy. Like, okay, I will always be reachable. So although you're saying, yeah, look, it's safe. Like once you know that the fetus has died and you have a failed pregnancy, you can just wait and you're not at risk of anything. But you do have that thing hanging over your head, like, is today the day? And what do I commit myself to doing? And do I have like a backpack full of clothes ready to go? And like, am I going to need help when all of this goes down? Like there's a big thing hanging there, right? Like, am I understanding this correctly?
Yeah.
Okay.
Yeah. So it's, every individual, and let me just back up to say, I mean, a miscarriage is a traumatic experience regardless. Okay. That, it doesn't matter. It's traumatic regardless. So, when we talk about in medicine, we're evaluating safety. My primary job is to keep people safe. And so we talk about safety first, and then once we identify what the safe options are, then we can talk about, okay, what are your other responsibilities? Do you have other kids? Do you have help at home? Do you have, is your husband going off where he's not reachable for periods of time because of his job? So every individual person has different constraints around them. And we have the luxury in the United States of being able to say, all right, we've got options here that are all safe and can meet your needs with the rest of your life. That's a unique life as compared to anybody else. So,
got it. Okay, and one more question before, and again, then I'll shut up and you keep going.
Okay.
In considering a DNC versus using with the meso and the meso or whichever you're talking about, like these are accepted completely. Like, this is part of our medical establishment.
Right.
Like this is part of our disease. Like if you like a gal comes into you, God forbid today, and says, and you guys determine like, okay, this is a failed pregnancy. You have these three options. Like there's no legality involved with any of these at this point. It's like, no. We can schedule for the OR today. We can get you this medication today. You can wait it out. But like we have established clearly within the guidelines of the legality of Idaho and the medical establishment of Idaho, like these are your three options, right? It's not like, well, it's 50-50. We're right. It's like, no, we're right. We're right. Like this is what we have.
Right.
Got it.
Yeah.
Okay.
And then and these things have all been done for decades.
Right,
I mean, I'm not particularly young, and they were all well established, well researched, well vetted options when I was in training.
Sure.
So these have been used for a long time.
And the question is not, should we continue to be able to do, for instance, like a DNC?
Right.
Like the question is not like, should we just make all women go to this 4 to 6, 8 waiting time frame? The question is, we have three options. Should we remove one of them?
Right.
It's like, well, okay, but we still have the other, like, it's not like it's just let nature take its course. It's like, no, we have other medical interventions. It's just surgery.
Right.
Got it.
So one of the newer developments over the last decade or so, maybe longer, I might be dating myself. I've been doing this too long, is the addition of mifepristone to treating miscarriages. So mifepristone was originally used and researched for medical elective abortion. And so tons of controversy surrounding this medication because of that, because regardless of what the Supreme Court says, abortion has always been very controversial.
And you as a medical practitioner have never engaged in elective abortion.
Right.
You're an OBGYN. It's not something you did in residency. It's not something you participate in here ever.
Right.
You're very aware of the objections.
Right. This is, I have never myself, that has not ever been a part of my practice, doing elective abortions. So mifepristone, that's what mifepristone was originally used for. Well, then they started to look at it with management of miscarriage, because one of the problems with using misoprostol in the management of miscarriages is, depending on the gestational age, so how far the pregnancy went before the baby died, there's varying success rates, and it's never 100%. So
interesting.
The idea is, all right, if a woman is wanting to use medication to treat her miscarriage, the goal is to get as close to 100% treatment effectiveness as you can. And it had been studied. There's a lot of different studies. The best quality study was a randomized controlled trial, showing that when you add mifepristone in a certain protocol, so you give the mifepristone before the misoprostol with a certain length of time, that it increased the effectiveness significantly. Also decrease, there's all these different, when you do a study, there's different outcomes that you look at.
Sure.
And one of the things, so it increased the effectiveness, also decreased significantly the likelihood that women would need a surgical procedure to finish removing
whatever tissue might be.
Right.
And when you say increase effectiveness, it means, okay, so we have somebody in there who's like, okay, I have this failed pregnancy. fetus is no longer alive. We know that conclusively. I don't want to do surgery. I don't want to just wait it out myself. I take the first medication, and there's a chance that that medication will not successfully get the body to expel the dead matter. So then you either have to continue waiting 4 to 6 weeks, or you have to engage in surgery.
Right.
And we would know that because it's like, okay, within 48 hours, this thing should happen. This event should happen. So like hang out by your house, like make sure you have your support, make sure you have childcare, things like that. This will happen. And for some portion, some percentage is like, no, nothing happens. And then you're just back on the waiting train. So you're saying if you actually if you team up with these two with a completely failed pregnancy that everybody understands, they're like, okay, this will increase the likelihood that you will have that event within that time frame.
Right. And it's not the only option, right? Sure. We've used misoprostol alone for a long time. There's also a protocol to use 2 doses of the misoprostol. There's a lot of nuances to this. So I don't want to misrepresent mifepristone as being absolutely essential to this, but it has shown value. And so I think the question becomes, okay, it's a medication, how much emotional value do we want to assign this medication? And I don't necessarily want to answer that question, but I do think that it's a valid question that all of us can ask, is that medication worth emotional investment on my part, or is it just a medication and we get to look at it as that and decide, does it have value for the patient care that we're trying to do, or does it not? And does it need to be anything more than that?
Very dark, but now when you're talking about that, I have seen depictions of people taking their lives where they like slug a bottle of aspirin or Tylenol and then like drain a pint of alcohol or something. And I don't like, this is thematic representations of it, but it is my understanding that like you can terminate your life if you take too much over the counter, aspirin, Tylenol, whatever. I don't know. And then like slug a bunch of alcohol. That's bad, right? But we don't outlaw Tylenol because we know that somebody could take their lives with Tylenol, right? And I don't know if that's quite the appropriate analogy, but it's like, okay, this can be used in this thing that we don't like, but it is also part of this very, very effective and useful treatment that nobody objects to over here, right? So when you're talking about emotional value, it's like we're going to get hung up on the emotional tie we have to really disliking this thing and let that emotional attachment bleed over into this functional. It's like, no, man, like I had a headache on Friday. It was terrible. Like, and I had lunch with my wife and she brought me some Tylenol and like, boom, my headache got knocked out. I was like, God bless it, man. Like headache's gone. We're eating pho, like having a great day. And yeah, like I'm sure there's somebody in the world who has very unfortunately taken their life with Tylenol, but like I don't have that emotional attachment to those 2 Tylenol when I pop them down because I got a headache. Right.
Yeah. And the other thing too, I talked, I think a little bit about this on the last time I was on, my background growing up as a homeschool kid in a state where it was legal, but in a time period where it wasn't legal everywhere in the US. And
that's homeschooling?
Homeschooling. Mm-hmm.
Oh. I didn't know that homeschooling had like a hot minute when it was illegal places.
Yeah.
Oh yeah.
So that dates me. I'm like, I'm getting close to being able to call myself vintage in some of these things.
Could I ask you a question real fast? With regard to education in the state of Idaho, there's a huge conversation around, and I'm not asking your school choice or anything, but one of the criticisms that people have with homeschooling is they're like, predominantly it's much harder. Usually it's much harder to teach STEM in a homeschool environment because you don't have lab equipment, you don't have like chemistry sets the same way, you don't have all these things. You're a doctor, right? Like you are an established, successful doctor, board certified, a whole bit. And obviously that required a lot of STEM along the way. Like what was your experience with STEM education as a homeschooler, if I may ask?
Well, that's a whole rabbit trail.
Okay, never mind that. Next conversation.
Maybe it's one of my favorite conversations. But
Another
Yeah.
day,
Yeah.
another day, because I would love to, to promote more STEM across
Right.
cross sectors, right? Like we need more STEM in homeschool and public school
Yeah.
and private school and charter school and moon school. Like I don't care, whatever.
Yeah.
We just need more people running around with STEM in their head.
Yeah. And you wind me up and let me go, and we'll be here for another hour.
Let's stay on target.
So one of the things that I remember, when I was a kid, I was thinking about this yesterday. Like, how old was I? I was maybe in middle school, and my parents took me with them to the board of the open board of education hearing. There were some rule changes coming up. There was a little bit of drama in our state for a hot minute. Turned out fine, but my parents took me with them, and I remember listening to some of the arguments from the people who wanted to make stricter rules around homeschooling. Like, you can homeschool, but then these used to be the rules, and now we're going to add all these other requirements too. And I'm listening to him, and I'm like, oh, that kind of makes sense. And I was talking to my dad about it afterwards, and I was like, well, Dad, that kind of makes sense. And he said, now, Megan, hang on. The people who are already being irresponsible homeschooling, the people who are being irresponsible homeschooling are already not following the rules. He said, adding more rules isn't going to do anything to catch those people because they're already not following the rules that are here. All it's going to do is make life harder for the people who are trying to do a good job. And that logic, that gets used, right, with gun control and all kinds of things, right? I mean, we're familiar with that concept that, like, okay, hang on, making more rules, is that going to address the behaviors we actually want to stop? Or is it going to hurt the people who are already following the rules we want them to follow? And I think this whole medication conversation is a great example of that. If we restrict access to misoprostol and mifepristone in Idaho, the people who are going to experience challenges are not people who are trying to do elective abortions. It's going to be the women with desired pregnancies who are experiencing a miscarriage. It's going to be the women who've just given birth to a baby and are hemorrhaging. Those are the women who will suffer.
And these medications are already restricted. Like you say restricted, like I can go pick it up at CVS.
Oh, they're all prescription medications.
Right. We also they're restricted.
Right.
You have to have a doctor who's like, oh my God, you've had a miscarriage, or oh my God, you delivered this baby and you're bleeding. Like, oh my God, we got to do something. Like they are restricted. It's not like it's Advil.
Right.
It's I mean, beyond that, you're like, okay, so not only do you have to have a medical professional board certified, the whole thing to even prescribe this stuff, but like you can only get it prescribed in these specific ways. Like that's, and to make it worse, it's like, well, then who are you stopping? You're only, if people are playing by the rules already, they have a doctor, the doctor's on board, all these things, she's like trying to save a woman's life or something. And it's like, yeah, let's remove a tool.
Yeah. Or make it harder to get, and that medication shortages are a problem on a regular basis. So that's these, especially misoprostol, is just not something that that sounds really miserable, having restricted access to that.
What are they advocating for it going through like a stronger chain of custody, or like what are the bills there? Because there are bills or people talking about this, right?
So mifepristone actually is already on a, and I'm going to have a brain fart, the name of the program with the DEA. It's already restricted and there's a ton of requirements. Like I've never been able to use mifepristone regularly in my practice because the paperwork to go through to get access to it is cumbersome enough that none of the practices I've been involved with has ever gotten to the point of having enough bandwidth to sit down and go through that process. So, which is a whole other conversation because for high risk this DEA program is supposed to be for high risk medications, and was originally intended to be high risk addiction medications. And so it's a little bit interesting that
This made it onto that list.
that the mifepristone made it onto the list. But again, it speaks to the controversy,
Sure.
right? That has always been around the whole topic. And yeah, it would be very interesting if misoprostol entered into that same realm.
Dr. Kasper, I learn something every time. Now I know I have to ask you about homeschooling. Your eyes lit up. Like, I want to know about this. Thank you for coming in today. Thank you for explaining this. Again, I don't know anything about the medical world, but I do have a wife and I do have 3 boys, and God willing, I will someday have 3 daughter-in-laws. That I want to have medical care in Idaho. I love this state. It's the best place that I've ever found to live. Like, it's great. And I want it to stay great. And I want it to stay great for everyone under all circumstances. Yes. I don't want my sons and my daughter-in-laws to consider having to leave to enter their child rearing years. I don't want that for anyone. So I really appreciate you coming in and giving these perspectives, because it's impossible that I would find this out otherwise. Because guess what? I'm not making an appointment with my wife's OBGYN to go talk to her about this. So thank you for taking the time. Thank you for what you're doing for Idaho. And thanks for coming to talk.
Thanks for having me on.